Today we are promoting World AIDS Day, and we are really excited to have Evelyn Letio on the line with us today, who is the program coordinator for the National Empowerment of Positive Women United. And my name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor, and I'm based here in Nairobi, covering East and Southern Africa, on behalf of the GBV AOR, which is the Area of Responsibility, the Global Coordination Mechanism for Gender-Based Violence in Emergencies. And I'm really pleased to be joined by my members of our team here. We have Christine Appio on the line, Ruth Mataya, and also Christine Cabelle, who are joining us from the GBV AOR team. And Shiva, we can't forget Shiva, who's always providing really great admin support and tech support from our Geneva office. So Shiva, a very early good morning to you, and we really appreciate your support as always. But more importantly for today, I am also the co-chair of the Regional GBV Working Group for East and Southern Africa, along with CARE International. We lead coordination here in the region. So welcome everyone. Today's discussion is only going to be 30 minutes because we wanted to make sure that Evelyn, who has a full schedule of activities, obviously because it is World AIDS Day in South Sudan, but we thought it was a good opportunity to learn more about what women-led organizations are doing in terms of working with HIV positive women who are also at high risk of gender-based violence. So it's a population that we hear about, but we often don't understand sort of the intricacies and nuances of the programming that is provided. And I think a lot of that has probably to do with the stigma and isolation that often HIV positive and also GBV survivors face on a daily basis. So we're just going to have a conversation with Evelyn today. We have a few questions to start us off. And then if others have questions, please feel free to write those in the chat and we can try and pose them to Evelyn as the time progresses. But we will be cutting off in exactly 30 minutes because here at the Regional GBV Working Group, we do like to keep time. And we know that everyone has a busy day today. So thanks again for joining. And welcome, Evelyn. How are you this morning?
Good morning. I'm fine. I'm so excited to be in this meeting, although it is for a short time. And already there are phones from everywhere finding out where I am. And I hope we shall really keep time. Thank you so much.
Thanks, Evelyn. So very quickly, Evelyn, before we get into the work of your organization, we thought it would be useful for you to give a background of the population that your organization serves. Can you tell us a little bit about who your, I'm not going to say beneficiaries, but who your organization specifically serves?
Thank you so much, Jessica. The organization serves many population groups. First of all, women and girls living with and affected by HIV. We also reach out to the key population groups, which is especially the female sex workers. And then we go to the vulnerable population. Those are the internally displaced population in our community. And then the community around.
And
Thank you.
Evelyn, when you talk about those categories that you mentioned are often the most marginalized individuals in the community. How do you find or how do you identify, for instance, female sex workers or other marginalized groups that you just spoke about?
Yeah, for these female sex workers, among them, there are those who are HIV positive. And when they hear our community giving education in the community, and then on the radio, on the media, then they reach out to them and say they are also HIV positive and they do not know how they can get support. That is how we penetrate the community of the sex workers.
So it sounds like what you're saying, Evelyn, is that a lot of it is through an informal network of referral, that those who are identified as HIV positive are often referring other women to your services.
In South Sudan, the key population groups are the most uh, uh, marginalized people. They face so many challenges, arrest, this and that. Um, so they don't come out openly. They secretly, they want to identify their HIV positive, but they stay together with in the groups, in the hotspots, together with those who are not HIV positive. But because of them, then we have access to reach the bigger sex worker groups.
Mhm. And what about children? You mentioned, I assume these are adult women, but do you have a population or a caseload that are also, or maybe tell us a little bit about what your caseload looks like. You don't have to identify anyone, but are you finding that they're older individuals, children, women of reproductive health or reproductive age?
We have all those categories: women of reproductive age, the older women, the children right from babies, because we also have prevention of mother to child transmission. So we are having this project targeting also the children, that to reduce uh, the new infection in South Sudan through the newborn children. So we give a lot of education and support to the women at productive age, and those that are tested positive, then we get closer to them. We bring them in a group, in a support group where we reach them often. In that way, we bring the children back for testing to ensure that they are free. And we continue following them up to ensure that until they are weaned, the children are safe from contracting HIV.
That's That's amazing. It's and life-saving, Evelyn. What and how are there trends in terms of that you're seeing within your organization on transmission in terms of this population? How off or how what are the characteristics of transmission really? You mentioned child or mother to child transmission. What are you seeing are the trends in terms of transmission?
Mostly in South Sudan, it is through sexual intercourse with the infected person. Our cultures here, I think, is quite different from the rest of the African countries. There is a polygamy, there is wife inheritance. One man can have more than 10 wives. So you can see in that way, once the man has the virus and they don't come out to say, once the man has the virus, all these 10 wives will be infected. And then, of course, the PMTCT, we talked the mother to child transmission. And for the blood, it is very rare because the blood these days, before they are transfused, they are screened. And maybe through other shops when people do not know, or during the what, maybe in an accident, that is when through blood products, infection can take place, but it is very rare.
So really, it sounds like the risk factors are most prevalent or most identified through sexual contact. And
Yes.
which brings me to my next question. What are you seeing in terms of, and I guess even those at risk of transmission? But then also for HIV positive women, we're often hearing of the intersectionality between HIV positive, being HIV positive, and also being at high risk of gender-based violence. Can you talk to us a little bit about some of the trends you're seeing in South Sudan in terms of the risk factors and then also the relationship between HIV and GBV?
Thank you so much. First of all, the relationship between HIV and GBV is that they both of them carry stigma, very high stigma and discrimination. And then secondly, because these women, in my country, a woman who goes for antenatal, all of them has to go through screening for HIV. And once they are positive and then they disclose, they go home and disclose to their husbands. That is where GBV happens. She is beaten, she's mentally tortured and chased out of the marriage without anything, including the whole family members. She is robbed of her children and just chased like that. Another thing is during the 2013 crisis and 2016 crisis in South Sudan, there was a lot of this sexual violence, a lot of it. And in that way, so many people got infected with some of them, most of them, actually, I should say, uh, more than 300 of our members got infected with the HIV because they were raped.
Oh,
So there is all this around in South Sudan. So it's really a very, very sensitive issue. And we are dealing with very, very difficult where here is a woman who is both HIV positive and who was raped. It is very difficult to bring them back to gain their self-worth. That stigma takes time to go.
and
So these are some of the relationship uh, because they are mentally tortured. The women who are HIV positive, they are mentally tortured because of those discrimination and abusive words, all those. They are divorced because of their status. Even when a man is taking medicine, will not disclose to the wife and will continue blaming the wife. You brought it, and you continue that, continuously have that mental torture. Yeah.
it's sort of overwhelming to think about, actually, Evelyn, when you think that, and you mentioned 300 on your caseload, just of those who were, who became HIV positive through rape, um, which is, it's kind of amazing just to even hear the scale of the number of people. And you mentioned so physical violence, sexual violence, and then previously you also mentioned things like wife inheritance, which in a way is a forced relationship and forced sex. And so we can't forget also, and even, I mean, sometimes we do have sex work that is legitimate work, but then also a large majority of women in crisis affected situations, they are forced into sex work just for the very fact they need to feed their families and they don't have other choices. And are you seeing that trend also, Evelyn, among sex workers as well?
Yes, yes, you are right, Jessica. Yeah, because most of these some sex workers who are here now, most those are not HIV positive. They came to Sudan for business. But when the businesses collapsed, they didn't have any other choice. They did not have any other way to go back and to survive. They had to join sex work. And you are right.
And we have some questions in the chat here, and one of them, and I'm going to come also to learn more about your organization in the next 5 to 7 minutes, but we have a question about confidentiality. We realize that even working with survivors of GBV, there's the importance of maintaining confidentiality. And I imagine that's equal or even more so when working with individuals who are also HIV positive. How do you ensure or maintain confidentiality in the community when you're doing your work, especially as an organization that's identified as working with HIV positive individuals?
Yeah, our volunteers are all trained on confidentiality issues. So they keep strict confidentiality. And unless it is the will of that client to talk to the family about her status, the volunteers can do to help her to come in between, to help her disclose to the family members, then they can do that. But otherwise, we have confidentiality issues because these are issues in some of the communities where we are working with, while once they know, they want to do away with you, to kill you. So we really look at that very, very critically. Some of our communities far north have not heard even about HIV. And therefore, once they hear that, that is the end. They said, let's clear this one before they multiply it in our community. So that is it. We are very, very conscious about that. Our volunteers are very conscious about that, except for themselves. That's why we are using only the people, the women that are living with HIV, and they are open about their status. Because if we bring somebody else who has not gone through the pain of being told you are HIV positive and the discrimination, the stigmatization you went through, it becomes very difficult for that person to keep confidentiality. We are strictly using the members that are HIV positive, and they are free from stigma. They are open on their status. And these are the ones, once in the community, they go for awareness, they stand up and say, I'm living with the HIV, and for so many years I have lived with it, and it is possible to live with it. Take the first step, ABCD. And when those that are positive hear that, then secretly they come to them, and because they leave also their contacts, either they call or secretly they reach out to them, and then they are connected to the support groups that are around.
So, Evelyn, I think this is a good transition into the last question because I know we have about 6 or 8 minutes left. Can you tell us, it sounded like, and maybe who are your volunteers? Are those volunteers women who've identified as being HIV positive? Can you tell us a little bit more about your organization and the specific services you are delivering, and who within your organization delivers those services?
Thank you so much, Jessica. And National Empowerment of Positive Women United was formed by women and girls living with and affected by HIV. When I say affected, it's either the wife is positive or the husband is positive. That discordance, we also accept them. But NEPU is purely for, is the organization of women and girls living with and affected by HIV. And I was one of the founder members. So we have seen the issues ourselves. We experienced a lot, and we do not want the other women to go through. So what we did is we thought it wise to have all these members who have come out openly to do the work for the organization in all the 10 states of South Sudan. So although we have the technical people at the secretariat, but all the voluntary work are the women girls and men living with HIV. We don't leave out men because some of the women have their husbands who are also HIV positive. What we do at NEPO is we provide treatment and care to the people living with HIV. What I mean by that, we deliver medicine because there are those, because of stigma, they don't want to appear at the what? At the hospital. So we don't want them to miss their medications. We deliver medicines to them at the community. Through the support group, we educate them on positive living. And there is a lot on positive living. And this is what makes the women strong and what makes some of the husbands also accept to live with their wives. After divorce, they can come back. We also have all this reconciliation for those families that broke out because of HIV. We have the reconciliation. We do um, we do also provide them counseling, continuous counseling, and then we give psychosocial first aid to the people that are referred to us who are uh, after the sexual violation, they are found to be positive. We continue giving them those. First, we give them that psychosocial first aid psychosocial support before and then after that, and then we connect them to the volunteers who are trained to handle these groups. We also provide the prevention of mother to child. I already told you earlier on. We keep these mothers to ensure that children remain HIV positive, checking their drawing the blood and bringing to the hospital to check the viral load to see whether they are suppressed or they are not suppressed. And then we continue providing for those that are not suppressed. We do also empowerment to these women who do not have chance of being volunteer with us. They're empowered to do some IGA so that they survive. We also have, as I said, the nutritional part of it. We educate them about hygiene and sanitation, all this, let me say, the continuum of care. We do follow it all across in the community to the people that are HIV positive. Above all, that testimony, as I said, is a very powerful tool that we have. A woman can refuse to take ARV when she's first tested positive at the NC. They can refuse. But because we think of the child, that testimony from one of the peer counselors, once they hear, I was also like that, and now I'm on treatment and I have produced HIV negative children, they accept easily. And then they keep it confidential between them, and they continue supporting them. Life continues to go, and they live very healthy, happy, and productive lives.
And Evelyn, I guess now, I mean, HIV is more of a chronic disease because we know that individuals are living up until, old age and dying of old age and not HIV or related diseases or AIDS. So I think that's a really, really strong point to reflect on what you've just said, living positively, and also seeing other people living positively and then also living healthily, right? One last question, and I'm going to put together some of these questions we had in the chat. I think you did mention community networks, that many of your sort of staff, I don't want to say staff, but community volunteers form their own networks. We also know you mentioned earlier, I'm seeing that Etienne put a question in there, that many of those that are referred to your organization are through word of mouth referrals. And so not necessarily associated with being a sex worker. But another question, one is related to post-exposure prophylaxis. And what is, because this is one of the key services or goods that we do here in the GBV service delivery community, is making sure that PEP is available at health centers. If you could talk a little bit about that. And then lastly, are you a part of, is your organization a part of the GBV referral pathway? Because I think this is another takeaway for all of us on the line in terms of what we can do in our own settings to strengthen our response to HIV positive women who are at high risk of GBV. So last question, Evelyn, is about PEP, post-exposure prophylaxis, and then also the GBV referral pathway.
Thank you so much, Jessica. Yes, NEPU is on the referral pathway, and that is how we get those that are raped and turned positive. They are referred to us. For PrEP, we have PrEP in South Sudan, although it is still new, it is starting, and we are starting to give to mainly the sex workers. We also have PEP. These two words are confusing, PEP and PrEP. We have also PEP, and this, as I said, the 300 people, more than 300 turned positive because they didn't get information on what to do after the rape. But in the community now, we are doing education on this GBV, telling them once you're raped or you know of anybody, before 72 hours, go to the hospital so that they are given that services. And we have been giving this, since we realized our members, most of them are positive because of GBV, we started doing the education, giving information on GBV, just basic information. Without any support, we integrated all this activity in our HIV program because we know that GBV can't work alone with HIV, or HIV can't work alone because of this complex in between the two. So on voluntary basis, we started doing this work. We report to the cluster voluntarily, and we are, the clusters recognize the work that we are doing, and we have been put on the referral pathway. Thank you.
Thank you, Evelyn. I know that our time is up. I just want to really appreciate you taking the time today because I know you have a very busy day ahead of you. And also just to appreciate the work that you are doing as a founding member of your organization, but all those community volunteers who are really the frontline workers and sort of the visible manifestation of what can be and the future for those who become HIV positive. And thank you for so very brilliantly articulating the relationship between HIV and then also, or the intersectionality between HIV and GBV. So thanks again, Evelyn. We really appreciate you and the work that you're doing. And please give a big hello from the Regional GBV Working Group from East and Southern Africa to all of your colleagues that you run into today. I know that I'm going to take your message with me today and throughout the year on how we can better strengthen those ties. So thanks again, everybody, for joining us, particularly Evelyn. And I hope you have a great afternoon. And I hope that you're promoting safe access to services for women who are HIV positive and also at high risk of gender-based violence. So thanks everybody for joining, and I hope to see you on Tuesday for our next big event for the 16 Days of Activism campaign. We will have a launch of our GBV and disabilities briefing note, and we hope to see you on Tuesday. We're going to be sending out those invitations today on behalf of the intersectionality pillar of the Regional GBV Working Group for East and Southern Africa. So thanks again, Evelyn, for all that you do. And thanks for everybody for joining us on the line, and have a great afternoon and weekend. Bye, everyone.
Thank you. Thank you. Thank you so much, Jessica, for this brief time. I hope we could
Bye,
have
everyone.
some more of this in future.
I
Thank you.
agree.
Have a blessed day. Okay.
Thank you very much.
Okay, bye.
Thank
Bye.
you, Evelyn.
Bye, everyone.
Bye, bye, bye,
Thank you all.
everybody.
Bye,
Thank you,
everyone.
Jessica.